today for our presentation. So just a little bit about her. She is a professor in the Lawrence S. Bloomberg Faculty of Nursing and the Faculty of Medicine, Department of Surgery at the University of Toronto, and a senior scientist at the Women's College Research Institute. She holds the Bloomberg Professorship in Cancer Genetics and is the Associate Dean of Research. Dr. Metcalfe's research focuses on the prevention and treatment of breast and ovarian and high-risk ovarian cancer in high-risk women, most specifically those with the BRCA1 or BRCA2 mutation. So with that, I'd love to pass it over to you for our presentation, Dr. Kelly.
Thank you, and thank you for the invitation to come and present. I wish I could see all of your faces and we could have more of an interactive discussion about this, because I'm very open to questions and comments and thinking about some of the important questions that we need to be thinking about in the future as we're thinking about breast cancer and genetic testing. So please type in your questions and we'll try to get to as many of them as possible. So today I'm just going to talk a little bit about breast cancer and genetic testing. And I'd like to start with just some basic information about genetics and breast cancer, and then really start to talk about some of the research that we've been doing at Women's College to try to advance this field, to try to leverage the information that we gain from genetic testing to make an impact on women's lives, both in terms of thinking about preventing breast cancer in those who haven't had breast cancer before, and also thinking about how we can use this genetic information to personalize cancer treatment in order to have an impact on survival rates. So I'm going to talk a little bit about some of that, and also thinking about some of the novel new models of care that we can think about when we're delivering genetic testing to women with breast cancer. So I'm sure you are all aware that breast cancer is common in women in Canada, as well as most countries around the world. About 1 in 9 women will develop breast cancer in their lifetime. So when we think about breast cancer and genetics and trying to understand why breast cancer happens, so for some women, there is a cue as to, or a clue as to why this has happened. And this is what we call hereditary breast cancer. So where the risk is inherited from a previous generation, and that risk can be inherited from either the mother or the father. So it can be coming from either sides of the family. So it's really important when you're thinking about your family history to not only look at your mom's side, where we often typically think about inheriting a breast cancer risk or an ovarian cancer risk, but we also need to think about your father's side. So looking at your father's relatives, are there a lot of breast or ovarian cancers in that side of the family? Because if there are, that's important for you to know in considering what your risk might be of having a cancer predisposition. So what's important to know, though, is that the majority of breast cancers are not due to this cancer predisposition that's being passed down from generation to generation. Most of these breast cancers are what we call sporadic breast cancers. They're just happen by chance. So thinking about cancers running in families, all cancers are somewhat genetic, but they're not all hereditary. And hereditary really means being passed down from generation to generation. So when we're looking at these families, we often see multiple generations with cancers that are associated with a certain gene. Some people are born with this genetic predisposition, and what we call these are genetic mutations. So there are genes in our bodies that we all have, and typically these genes are meant to protect us from ever developing cancer in a specific organ. So today we're talking about breast cancer. However, there are certain people that have a mistake in these genes that protect us, called a mutation. And really that's what predisposes the individual to having an increased risk of developing cancer. But it's important to remember, and I've just talked about this, that the mutation is in all cells of our body, and that includes both the eggs in women and also the sperm in men, so that it can be passed down from a father, even though the father doesn't have any diagnosis of cancer himself. So if a person inherits one of these genetic mutation, his or her risk of developing cancer is increased. And this is what we refer to as hereditary cancer. So what do we look at when we're thinking about hereditary cancer? And that's not to say that this list is exhaustive, and there are many families where we don't see these typical characteristics. But in general, especially when we were initiating genetic testing for some of these cancer predisposition genes back in the mid to late 1990s, these were the types of families we were looking for. Multiple individuals with cancers, looking at different generations. So we could see it throughout history in terms of the number of cancers. The other thing we look at is age of onset. So a young diagnosis of cancer is often a clue to us that there may be something hereditary going on, or if an individual has had more than one type of cancer. For example, if she's had a diagnosis of both breast and ovarian cancer, again, a cue to us. We also look at things like male breast cancer. Again, not a common type of cancer diagnosed in men. So when we see that, again, it could be a clue to us that there's something going on in the family. There are also certain ethnic groups that have a higher risk of having one of these genetic mutations, including the Ashkenazi Jewish population. So important to look at all of these different characteristics, and again, looking at both sides of the family. So today I'm going to focus a lot on BRCA1 and BRCA2, and these were the two primary breast cancer genes that were diagnosed in, or were discovered in the mid-1990s. Like I said before, in terms of how these genes work, we all have two copies of BRCA1 and BRCA2, and we get one copy from our mom and one copy from our dad. When these genes work properly, and when there isn't a mistake, they work to protect us against developing cancer. However, if someone inherits a BRCA gene from one of their parents and there's a mutation or a mistake in that gene, that's when a person is at an increased risk of developing cancer in specific organs like the breast, the ovaries, and there are other organs where these cancers can also develop. But typically, the highest risks are in the breast and in the ovaries. So if you're told that you have a BRCA1 or BRCA2 mutation, often you'll hear people refer to it in different ways, but it could be that we're thinking about is that you're a carrier of one of these BRCA mutations. So that means that you have one copy that's working and one copy that's not. So you can see over here, if we're thinking about the green being copies of BRCA1 and BRCA2 that don't have a mistake in them. So you can see here that this parent has one working copy and one copy with a mistake or a mutation. So with every pregnancy, they're going to be passing one of those copies down to their offspring. And you can see with every pregnancy, there's a 50% chance of a parent passing that mutation on to his or her child. So again, that's why we see the increased number of cancers, because really it is, if someone has one of these mutations, with every pregnancy, there is a 50% chance of passing that mutation on. However, if a person does inherit one of these mutations, so they have a copy that's not working properly, it doesn't necessarily mean that there's a 100% chance that they will develop cancer. We know that there are certain modifiers of risk, and for someone who's having genetic testing and is identified with one of these mutations, we have that discussion in terms of what can reduce your risk of developing cancer. So like I said, the main risks for these women are breast and ovarian cancer. We also know with the ovarian cancer is fallopian tube cancer, and there are hypotheses that ovarian cancer actually starts in the fallopian tube. So when we're thinking about prevention in these women, it's important that the ovaries and the fallopian tubes are both removed and not just the ovaries, but that's typically what's done in clinical practice now. So I just want to put this in perspective when we're thinking about the risks of cancer in people with a BRCA1 or BRCA2 mutation. And you can see the blue lines are the lifetime risk of developing that specific type of cancer. So you can see for the average woman, she has just over 11, 12, 13% risk of lifetime risk of developing breast cancer. Compare that to someone with a BRCA1 or 2 mutation, and you can see it's striking to see the difference in terms of the risk of developing breast cancer. And these women have up to an 80% lifetime risk of developing breast cancer over a lifetime. Again, the ovarian cancer risk for the average woman, it's about 1.5% lifetime risk of developing ovarian cancer. But for these women, about a 50% risk of developing ovarian cancer. And you can see some of the other cancers as well that are associated with these genes. But what's important message to take away here is that these individuals, both men and women, have an increased risk of developing cancers in their lifetime compared to an individual in the general population without a BRCA1 or BRCA2 mutation. I'm talking a lot about BRCA1 and BRCA2 today, but there are other genes that have been more recently discovered. And there's a list of them here. You may have heard of some of them. Typically, when we're doing genetic testing now for women who have an increased risk of having hereditary breast or ovarian cancer, we're not just testing for BRCA1 and BRCA2. What they're doing typically now is what we call a panel genetic test that includes multiple genes on that panel. So you're being tested for all of these genes at the same time. I'm not going to talk a lot about these genes today, but what I want you to know is some of these other high-risk genes don't generally come with as high of a risk of breast cancer. These are what we consider moderate risk genes. So there is a definite increased risk of cancer compared to the general population, but overall the risks of cancer, specifically breast cancer, are lower in women who have a mutation in one of these other genes compared to women with a BRCA1 or BRCA2 mutation. So how do we think about managing these cancer risks? It's really dependent on whether or not a woman has had a cancer or not. So for women who have not had cancer, either breast or ovarian cancer, we're thinking about how can we reduce the risk that a woman ever gets breast or ovarian cancer. So for those women, there are options available, including risk-reducing surgery. So a bilateral prophylactic mastectomy is an option for women who have not had breast cancer in the past. We know that this offers a very high protection against developing breast cancer. The risk of breast cancer then becomes lower than what we would observe in the general population. However, that's just an option. There is a recommendation for preventive surgery to have the ovaries and the fallopian tubes removed. We know this surgery offers not only a risk reduction of ovarian cancer, but it also significantly reduces the risk of death in these women with a BRCA1 or BRCA2 mutation. So again, this surgery is recommended. It's not presented as generally an option. We really want to work with the woman to get her to the point that she is thinking about having her fallopian tubes and ovaries removed. This is what we call a bilateral salpingo-oophorectomy. Again, thinking about that, depending on whether or not you have a BRCA1 or 2 mutation, there's a slight difference in age recommendations for BRCA1. It's around the age of 40, for BRCA2 around the age of 50. There are also chemoprevention options available for these women, including taking a drug called tamoxifen, which some women have for the treatment of breast cancer. It's also used to reduce the risk of ever developing breast cancer. And also these women are eligible for very intensive breast screening using annual mammography and MRI, and it starts at a much younger age. For women who have had breast cancer, we use this genetic information in terms of thinking about her treatment. And that's what I'm going to talk a lot about today. How can we use genetic information to inform treatment decisions with the ultimate goal of increasing the chance that a woman will survive her breast cancer? So like I've talked a little bit about in terms of risks of cancer, I've talked about what the overall lifetime risk is, but what I also want you to be aware of is the ages at which these cancers are diagnosed. So you can see here, the darker line is BRCA1 and the yellow line is for BRCA2. Again, a high lifetime risk of developing cancer. You can see at age 80, it's upwards close, between 70 and 80% risk of developing cancer. What's important to notice is when these cancers start to develop, which is very different than what we might typically see for the average population, the general population developing breast cancer, where we don't often, I'm not sure why that keeps flipping, see these young ages of onset. But you can see here that these women, the risk really starts in the 20s and it goes up over time. And it doesn't level off by age. In fact, it keeps increasing. So when women are thinking about preventing breast cancers, if they want to reduce that risk of ever having breast cancer and are electing to have a bilateral mastectomy, we really want to do that at a young age before we start to see that increased risk. You can see that by the age of about 36, she already has a 20% risk of developing breast cancer. That's very high for a 36-year-old woman. So again, important, especially when we're thinking about genetic testing, we want to do it at a young enough age that we can use that information to inform risk reduction, but also to be informing treatment of BRCA-associated breast cancer. So for a woman who is diagnosed with breast cancer and has a BRCA1 or BRCA2 mutation, she also has a high lifetime risk of going on to develop a second breast cancer. That breast cancer can develop in the same breast, and it's not a recurrence. It is a new cancer. And you can see in this figure here that at 15 years, she has another 16% risk of developing a new cancer in that same breast. So that's 1% per year. A high risk to consider, especially considering that these women are diagnosed often at a young age and have a very long life expectancy when we're thinking that they're only 30 or 40 years old when they're being diagnosed with breast cancer. It's not like a woman who's being diagnosed with breast cancer at the age of 80, where we wouldn't expect to see overall a life expectancy much more than 10 more years, even if she didn't have breast cancer. So thinking about that, we have to think differently about these kinds of breast cancers because they're often diagnosed at a young age. These women also have a high risk of going on to develop a breast cancer in the opposite breast. This is called a contralateral breast cancer. Again, it's not a recurrence. It is a new breast cancer. And at 15 years, a 34% risk of developing a contralateral breast cancer. So 2% per year. So these women have a high risk of going on to develop a new breast cancer, either in the same breast or in the opposite breast. Again, important information to think about when we're thinking about how these breast cancers should be treated. Thinking that we need to think not only about their first breast cancer and treating that, but also preventing that second breast cancer from ever happening. Genetic testing can be done at different time points. So we've talked a little bit about women who are tested and are identified with a mutation before they develop breast cancer, where then the goal really is on reducing her risk. However, many women are diagnosed when they have breast cancer. So this could be at the time of breast cancer diagnosis. Either she knew that she had a BRCA mutation before she developed breast cancer, or she has access to have rapid genetic testing at the time of breast cancer diagnosis to use that information to inform her treatment decisions. Or a woman can have genetic testing after she's had breast cancer, she's been treated for that first breast cancer, and then she's tested. And again, then the goal really becomes preventing those new cancers from happening. So the question really is, and I've presented some data to suggest that these cancers are different than women without a BRCA mutation. The question in our mind at Women's College, we were doing a large study thinking about, well, if these cancers are different, should they be treated differently? Should women with a BRCA-associated breast cancer receive the same treatment as what we would generally offer women with sporadic breast cancer? Those are the women without a BRCA1 or 2 mutation. So many of you know the typical treatments that may be offered for breast cancer. Often women are, well, most often women are offered surgery. This could be a lumpectomy, or what we call breast conserving surgery, where just the tumor and some surrounding tissue is removed. Or she could have a unilateral mastectomy, so the breast where the cancer was detected is removed. Or she could have a bilateral mastectomy, where the breast with the tumor is removed, in addition to the opposite breast in which there is no cancer. So she's thinking about removing that breast to prevent another cancer. A woman is often offered chemotherapy either before surgery or after surgery. There are often other adjuvant therapies that may come along, hormonal therapies, endocrine therapies, and she may or may not be offered an oophorectomy, which is the removal of her ovaries. So let's think about the effects of some of these treatments that she may be offered on survival. We know in the general population, when we're thinking about the surgical treatment for breast cancer, there is no survival advantage associated with having more extensive surgery. So survival in women with a lumpectomy is the same as survival in a woman with unilateral mastectomy or bilateral mastectomy. The more extensive surgery is not offering a survival advantage in women with in the general population. However, this was a study that we did at Women's College. We included women from throughout North America that had a BRCA1 or BRCA2 mutation. And what we did was we compared women who had a bilateral mastectomy to women who had a unilateral mastectomy. So one breast, for those with a bilateral mastectomy, the contralateral breast was removed preventatively, as opposed to women with a unilateral mastectomy where only the breast with the cancer was removed. And what we saw was that and we looked at long-term survival. Often when you see research, they're reporting on that very short-term survival. So typically up to 5 years. We followed these women for a long time, up to 20 years. And what we saw was that over 20 years of follow-up, the risk of dying of breast cancer was reduced by 52% in women with a bilateral mastectomy compared to women with a unilateral mastectomy. Remember, these women have a high chance of developing a second breast cancer. So by preventing that second breast cancer from happening, we were actually having an impact on their overall survival and reducing that risk by about 50%. So here you can see, just demonstrated in a figure, we're looking at years of after diagnosis. So this is from years 10 to 20. You can see along the bottom here, following them. So they were diagnosed over here. We followed them to 10 years and then 10 to 20 years. And you can see women with a contralateral mastectomy, so having a bilateral mastectomy to treat that unilateral breast cancer, their risk of dying was very low. compared to women who did not have that contralateral breast removed preventatively, again, their risk of survival continues to decrease over time. Most probably due to the fact that they go on to develop a contralateral breast cancer. So if we could have done surgery to prevent that contralateral breast cancer from happening, we would have reduced her risk of dying of breast cancer. So this is, again, just the same study talking a little bit about the impact of having a diagnosis of contralateral breast cancer. And within that time frame, 20 women died between the years of 10 and 20. And of those, many women had experienced a second primary breast cancer, either in the same breast or in the opposite breast. So it's important to think about this when a woman is making a decision about what surgery is best for her in terms of what her goals are in treating her breast cancer. What about oophorectomy on survival? Remember, these women have an increased risk of developing ovarian cancer as well. Typically, we don't see those ovarian cancers happening until, for BRCA1, they start to really increase in the 40s. BRCA2 really start to increase in the 50s. But again, we showed here that oophorectomy, so a woman who has her ovaries removed with a BRCA1 or 2 mutation, we're not talking about women in the general population without these mutations right now, just BRCA1 and 2. You can see here that how important oophorectomy was in terms of breast cancer specific death. So again, having her ovaries removed reduced her risk of dying of breast cancer by 53%. And if we look at all-cause mortality, and this includes ovarian cancer as well, we reduced her risk by 61% of dying of any cause. So again, important information for women making decisions about this. It's very unfortunate when we see women who are treated for breast cancer, survive their breast cancer, get through their treatment, are going on with their lives, and then are diagnosed with ovarian cancer when we could have prevented that ovarian cancer from ever happening. So again, this is the same, thinking about the same information on survival. This is specifically just in BRCA1. So this was a larger study, an international study. Again, some of the same data. So we're really, in different data sets, able to show that oophorectomy reduces all-cause mortality for these women, and also it reduces the breast cancer specific mortality. So there's something about removing the ovaries that also has a positive impact on the breast cancer and the risk of that breast cancer recurring and causing death in these women. Again, you can see the curves here when we're thinking about this. So this is years from diagnosis of breast cancer, a 10-year follow-up study. You can see the women who did not have their ovaries out. You can see here their survival is much worse than women who did have their ovaries out. So an important consideration to think about, there are very few treatments really that a woman may be offered for breast cancer that will have this big of an impact on her survival from breast cancer. So again, highlighting the importance of knowing if you have a BRCA1 or BRCA2 mutation when making treatment decisions. I'm going to go through this quickly, but thinking about chemotherapy. So this was a study that we looked at in terms of just including BRCA1 and just with stage 1 breast cancer. So again, a breast cancer that we would expect to do quite well. It's an early stage breast cancer. And sometimes women with stage 1 breast cancer are not offered chemotherapy because of the high chance of survival in these women. So this is a graph showing the difference between women who received chemotherapy versus no chemotherapy. This is women with stage 1 breast cancer. This figure shows that the survival rate at 15 years is very high, 90%, what we would expect for a woman with a stage 1 breast cancer. These are women without BRCA1 or 2 mutations. This is the graph for women with a BRCA1 mutation. You can see here that women with a BRCA1, remember this is BRCA1, this is no BRCA1 mutation. The women in the black line here, the darker line, you can see they receive chemotherapy. Very similar to what we would observe for stage 1 breast cancers without a BRCA1 mutation. However, women with a BRCA1 mutation who did not receive chemotherapy, you can see that their survival is not as good as those who did receive chemotherapy. So again, this really highlights the importance of knowing if you have a BRCA1 or 2 mutation at the time of diagnosis to use this information to inform treatment. What about other treatments? There's some exciting new research that's coming out now looking at the use of PARP inhibitors. So a common drug that we hear about a lot now is olaparib. And this was a study that came out late last year, looking at women with a high chance of recurring who had a BRCA1 or BRCA2 mutation. So these women were being treated very aggressively. And then they were given, so in addition to the standard treatment that they were given to treat these aggressive breast cancers, they were also given another drug called olaparib. So once they finished their chemotherapy, they started on olaparib. And although it's difficult to see and it doesn't look like that big of a difference, again, this is not even 4 years, so just over 3 years after diagnosis, but you can see the curve starting to separate. And you can see the difference in the number of deaths that happened in these two groups. So the yellow line is women who received olaparib, and the blue line is those who received a placebo. So they did not get the drug. They received a placebo instead. But you can see there's a difference in the total number of deaths. And we expect over time that these curves will continue to separate, and we will continue to see a survival advantage associated with taking olaparib. So again, this is ongoing research. I think it's really exciting research when we're thinking about the treatment of BRCA-associated breast cancer. But again, highlighting the importance of knowing if you have a BRCA1 or 2 mutation at the time of breast cancer diagnosis. So we know now, based on the research, that there is improved survival in women with the BRCA1 or BRCA2 mutation, depending on the type of treatment she receives. So there are a lot of questions I think we need to think about, and we need to think about whether or not all women with breast cancer should be tested, or just some women who meet some of those criteria we talked about earlier. When should women be tested? And thinking about new models of care. So the American Society of Breast Surgeons a few years ago came out with a consensus guideline stating that genetic testing should be made available to all women with breast cancer, including those at the time of breast cancer diagnosis or those who have had breast cancer in the past. This is something that we need to make available. We know that there are certain criteria in terms of who is able to be tested, who is eligible to be tested for these genes in terms of family history, personal history of cancer. And we know that there is a high prevalence of mutations in any woman with breast cancer. So this is a study that was done looking at almost 500 women. They didn't look at when the woman was diagnosed. They didn't look at if she had a family history or not. But when they just tested every consecutive 488 women with breast cancer, they found that 10% of those women had a mutation. Of those 10%, 6% were in BRCA1 or 2. So this is 6% of all breast cancers that could benefit from knowing if they have a BRCA1 or BRCA2 mutation and use that information to make treatment decisions. So again, let's go back to when these women can be tested. They can be tested at the time of diagnosis, or they can be tested after a diagnosis. So if we're thinking about women who are tested after a breast cancer diagnosis, so they've had a breast cancer, they've gone through their treatment, what do women do if they then receive genetic information? So this was a study that we looked at, looking at uptake of contralateral prophylactic mastectomy, so removing the breast that doesn't have breast cancer. We wanted to know what that uptake looked like. So these women found out that they had a mutation after they'd been treated for breast cancer. This was, again, an international study. And what we found was that the uptake of removal of that contralateral breast cancer or breast was actually quite low, especially in Europe. Only 6% of women had their contralateral breast removed. And in North America, again, it was 29%. And what did this actually translate into when we're thinking about a woman's decision about removing her breast prophylactically, so that opposite breast? You can see here the North American women are in blue and the European women are in yellow. And this shows their risk. This is the whole cohort of women from North America, the whole cohort of women from Europe. We know that fewer women in this cohort had their contralateral breast removed as opposed to this cohort. However, only 29% did. But you can see that over the years following that diagnosis, that they are at lower risk of developing contralateral breast cancer. The North American women are than the European women. However, we could bring that blue line down to very close to zero if women elected to have a contralateral prophylactic mastectomy. So what about at the time of diagnosis? And I'm going to, just in the interest of time, I'm going to go through this quickly. This was a study that we did at Women's College where we did rapid genetic testing. So a woman was diagnosed with breast cancer. Her surgeon referred her into this study. She received immediate genetic testing. So we were able to get that genetic test result back to her before she had initiated any treatment. So we got those results back within 10 business days. And we were looking at other outcomes, not just what she did in terms of surgery, but we were also interested in, was this impacting on her psychosocial functioning? We know that this is a distressing time for a woman to be diagnosed with breast cancer. If adding genetic testing was going to increase that distress, maybe it isn't the best time to be offering it. So these women had to meet criteria. They were more relaxed than the provincial criteria for genetic testing. It was their first breast cancer. They'd not had prophylactic breast surgery in the past, and they'd not had genetic testing in the past. In addition, they had to meet one of the following criteria. They were Jewish, they had triple negative breast cancer diagnosed at age 50 or younger, they had some family history of breast cancer, or they had synchronous bilateral breast cancer. So they just had to meet one of those. This was a study, again, it was over 1,000 women that participated in this study. You can see that the ages of diagnosis, again, often these are young women that met the criteria. Age was the most criteria met most often. And you can see that many of these women did not meet the provincial criteria for genetic testing. So 45% did not meet the criteria for testing. What was interesting, though, was we wanted to know if women used this information to make decisions about their treatment. Remember, I showed you that if they found out after, really very few women elected to have their contralateral breasts removed. But you can see here in this study, 72% of women elected to have a bilateral mastectomy if they had that genetic information available to them at the time that they were making treatment decisions. Again, within the first year after diagnosis, 40% of women had already gone on to have their ovaries removed, highlighting the importance of providing rapid genetic testing at the time of breast cancer diagnosis. Again, I was really interested to know Were we causing harm to these women if we were offering genetic testing at the time of diagnosis? And you can see here in the graphs, so this is the blue line are women who we found having a BRCA1 or 2 mutation. The red line are negative. The green line is something called a variant of unknown significance. Again, it's very similar. The risks are similar to a negative. So they're counseled as if they have a negative genetic test result. But what's striking is and this is measuring cancer-related distress. This is a standardized questionnaire measuring distress specifically related to their diagnosis of breast cancer. You can see we measured it at baseline, so the time of diagnosis, again at 1 week, and then 1 year after diagnosis. And you can see there's no significant differences between what your genetic test result was. It's really just a function of time that your distress goes down after your breast cancer diagnosis. Again, we looked at depression and anxiety, no significant differences. Again, just a function of time to get those levels down. So we know that the ultimate goal for genetic testing is to reduce mortality. We want to use this information to reduce the chance that a woman ever develops or dies of breast or ovarian cancer. We want to think about reducing that first breast cancer in terms of prevention for those who have never had cancer, reducing the risk of a second breast cancer in those who have had a previous diagnosis of breast cancer, reduce the risk of other cancers, especially ovarian cancer. And then also thinking about once we identify a woman with the BRCA1 or 2 mutation, we can then test all of her relatives. We can determine whether or not a relative carries that same BRCA1 or 2 mutation and counsel them in terms of what their risks are of developing cancer and how we can work together to prevent those cancers from ever happening. So I'm just going to finish off by saying, I think I've provided some evidence today that genetic testing is important when making treatment decisions. And we know that these personalized treatments can increase the chance that a woman survives her breast cancer or survives a subsequent cancer, prevents those cancers from ever happening. There are benefits, though, associated with genetic testing at the time of diagnosis, and I am an advocate for ensuring that happens. We've developed a new model at Women's College that we're testing right now, where a woman doesn't even have to come into Women's College Hospital. We do it all virtually. We send the woman a saliva kit directly to her home. She spits in it. She sends it back to us, and we get those results to her within 7 days. So she can be anywhere in Canada and have access to genetic testing at the time of breast cancer diagnosis, because we believe this is so important. We're still have to learn a lot more about those other genes that I talked about at the beginning. We know that they may not have as high a risk of initially developing a breast cancer, but it still may be important to know about those genetic mutations when considering how to treat those breast cancers if they're identified with, say, a POLB2 or an ATM mutation. How do we treat those breast cancers? So that is research that we are doing right now, so that women can benefit from knowing about other genetic test results, not just BRCA1 and BRCA2, when making these treatment decisions. So I'm just going to end there with a funny little cartoon to bring some lightness to this. I got one of those DNA kits. Turns out I'm 85% water, 8% dirt, and 7% dog pee, and I'm sure we can all relate to that on this snowy day. So I'm going to open up to questions. I know that was a whirlwind. I hope, and I have left enough time for questions, so I'm glad to hear that. So please enter your questions. I don't think you can talk, but you please enter them. And if you do have individual questions, I'm more than happy to take those by email if you wanted to email me directly.